Lumbar spinal stenosis, presented by Courtney Veschel and Brianna Smith. There are two types of stenosis. Central stenosis is a narrowing of the spinal canal around the cauda equina. This can be caused by facet joint arthrosis and hypertrophy, thickening of the ligamentum flavum, bulging intervertebral discs, and spondylolisthesis. Lateral stenosis is encroachment of the spinal nerve in the lateral recess or the intervertebral foramen. This can be caused by facet joint hypertrophy, loss of intervertebral disc height, disc bulging, and spondylolisthesis. Prevalence of lumbar spinal stenosis. It is the most common condition associated with lumbar spine surgery in patients over 65. It mainly affects people 50 years of age and older. In the United States, the prevalence is between 8 and 11%. By 2021, it has been estimated that it will affect 2.4 million Americans. There has also been shown there is no difference in prevalence between the sexes. There is currently no gold standard to diagnose lumbar spinal stenosis. MRI is currently used as the best imaging to diagnose. New studies are showing that 3D MRI may be better than conventional MRI for diagnosing it. 3D MRI has a sensitivity of 90% and a specificity of 93%, compared to a sensitivity of 63% and a specificity of 100% for a conventional MRI. 3D MRI also has an AUC value that is significantly higher than the one for a conventional MRI. The extent of narrowing of the spinal canal correlates poorly with symptom severity, and radiologically significant lumbar stenosis has been found in many asymptomatic individuals. This is an MRI showing severe lumbar spinal stenosis in this area. Diagnosis of lumbar spinal stenosis requires a combination of characteristic symptoms, physical examination results, and radiological evidence for a true diagnosis. The symptoms that have the highest sensitivity for lumbar spinal stenosis include radiating leg pain, thigh pain, and pain that worsens with standing, or neurogenic claudication. The symptoms that have the highest positive likelihood ratio for having LSS include bilateral buttock or leg pain, the absence of pain when seated, the improvement of symptoms when bending forward, and a wide base gait. Common symptoms for lumbar spinal stenosis include a long history of low back pain, bilateral neurogenic claudication, numbness and tingling, weakness, unilateral radicular symptoms, and one study showed that 90% of patients with lumbar spinal stenosis had leg pain. In a physical exam, a PT may find decreased lumbar extension, loss of lordosis, a forward flexed gait, a positive stoop test, which involves having the patient walk with an exaggerated lordosis until neurogenic claudication symptoms appear or are worsened. The patient is then asked to lean forward. A reduction of neurogenic claudication symptom is a positive test and suggests that the patient does have neurogenic claudication. There also may be signs of radiculopathy and possible motor weakness or sensory loss. There may be lengthened and weakened gluteus maximus and hamstring muscles, and short and tightened iliopsoas and rectus femoris muscles. These patients frequently will have normal exam findings, so it has been shown that symptoms are more helpful than actual physical exam findings. The PT also needs to be sure to ask the patient if they have any signs of cauda equina.
Physical therapy intervention. An April 2015 study published by DeLittle et al. In the Annals of Internal Medicine shows that physical therapy is just as effective as decompression surgery for relieving symptoms and improving function in patients with lumbar spinal stenosis. The treatment program consisted of 4 categories of exercises that were found to be most effective in treating lumbar spinal stenosis. These exercises were flexion exercises, aerobic exercise, lower extremity strengthening exercises, and lower extremity flexibility exercises. The flexion exercises consisted of posterior pelvic tilt, flexion in supine, flexion in quadruped, and flexion in sitting. The aerobic exercise utilized is treadmill walking and stationary cycling. Lower extremity strengthening exercises included strengthening of the gluteus medius, gluteus maximus utilizing bridging, the quadriceps, and closed chain kinetic exercises. These closed chain kinetic exercises were a half squat. Lastly, the study used lower extremity flexibility exercises. They stretched the hamstrings and the hip flexors. Some other physical therapy treatments include manual therapy techniques to improve mobility and stiffness, postural education, body weight supported treadmill walking, ice, and electrical stimulation. The prognosis. A study by Johnson et al. Looked at the natural progression of lumbar spinal stenosis in 32 patients with symptoms and neuroimaging consistent with lumbar spinal stenosis. These patients were followed for 49 months without surgical intervention, and it was found that symptoms remained unchanged in 70%, improved in 15%, and worsened in 15%. According to the study by DeLitto et al., 169 participants were randomly assigned to a surgical decompression group or physical therapy group, and after 2 years, patients in both groups experienced a similar reduction in pain and other symptoms. Also, 15% of patients improve with conservative treatment. However, 70% will continue to have neurogenic claudication and will need surgery for further treatment. 3 outcome measures are typically utilized to measure lumbar spinal stenosis. The first outcome measure is the short form 36 health survey. The MCID, or minimally clinically important difference, has not been established for this outcome measure. The SF36 is a 36-item generic self-report measure of health status covering 8 domains, including physical functioning, role limitation as a result of physical health problems, role limitations as a result of emotional health problems, energy fatigue, emotional well-being, social functioning, pain, and general health perceptions. Each subscale is scored from 0 to 100, with 0 being poor health and 100 being optimal health. This outcome measure has been used in numerous studies of patients with low back pain and has well-established psychometric properties. The Oswestry Disability Index is another outcome measure typically used. This has a minimally clinically important difference of 6 points. This disease-specific measure is a disease-specific measure that results in an index of a patient's perceived level of disability due to low back pain based on 10 areas of performance. These 10 areas include pain intensity, lifting, sitting, standing, walking, traveling, personal hygiene, social activity, employment, homemaking, and sleeping. A score from 0 to 20 is minimal disability, 21 to 40 is moderate disability, 41 to 60, severe disability, 61 to 80, crippling back pain, and 81 to 100 is extreme. The last outcome measure is Fear Avoidance Belief Questionnaire. This questionnaire quantifies the level of fear about work and physical activity a patient may have. The minimally and clinically important difference in this study is 13 points. This study also uses 2 subscales. Higher scores represent fear avoidance beliefs. A score of less than 20 is not a big indicator of long-term disability. Scores of 20 to 30 indicate 2.35 times more likely to have long-term disability, and a score of greater than 35, the patient is 5.15 times more likely to have long-term disability. These are our references. Thank you for listening to our presentation.